ల్యాప్టాప్ చూస్తున్నాం మనం పైన పని చేసినాం.
Good morning, everyone. First of all, I would like to thank the organizers for giving me this opportunity, everyone. So, first talk, I would like to start with the basic, most essential thing for postgraduates and radiology. It's not very uncommon for us that we encounter such injuries. A lot of patients do present us with this cricket ball sort of injuries, and most of the times they are mistreated or misdiagnosed as a simple sprain of the finger. And we do miss a lot of injuries. Also, fallen outstretched hand is a very common injury which we have, and only distal radius, etc. Those fractures are commonly diagnosed, but other complex fractures or scaphoid fractures, these are often missed. So if we see, there can be sometimes inadequate or improper views which can conceal our diagnosis. This patient, for example, he presented with a cricket ball injury, and he had a pain in the middle finger. When the consultant has taken X-ray, he has taken the X-ray of the middle finger, AP, and hand oblique. So when we take such injury, such X-rays for such injuries, usually we miss the diagnosis, proper diagnosis. So what we have to do for such injuries is always take a lateral X-ray of the specific finger only. Only on lateral X-ray you can clearly make out that there is a fracture dislocation. When you take a AP and oblique view for for a finger injury, it does not show you correct information. So that will mislead and give us a wrong diagnosis. Similarly, sometimes inadequate knowledge. You don't know how to read a X-ray. So the attending the surgeon thought that it is just a thumb injury and some small undisplaced fractures here. So he treated him by a cast application. And again, an important injury was missed. There was a CMC dislocation of all second to fifth joints. So because of inadequate knowledge on how to read the wrist X-ray or the hand X-ray, this was missed again. Similarly, inadequate exposure. So when the patient presented to him, because of budget constraints or something, the consultant has taken only an AP view, and he has thought it's just an ulnar styloid fracture, and he immobilized and sent him away because he thought the ulnar styloid fracture would heal away. But the pain persisted, and when he came to us subsequently, we could see that he has a chronic lunate dislocation which has not been diagnosed initially, and later it was found out that the lunate is dislocated, and that becomes very difficult for us to handle later. So inadequate exposure, inadequate knowledge, and inadequate views, all these three things together make orthopedic diagnosis in hand very difficult. So today's topic, we will see how to get proper views and proper diagnosis. So we'll divide the talk into three sessions: how to get the right views, how to position the hand for getting a right view, and then how to read the X-ray. So how many views should we need for a hand injury, and what views have to be taken? And how to position the hand also is very important, especially for the wrist, and especially for scaphoid views, you should know how to position the hand. That is another important thing, because without proper positioning, again the X-ray can be wrong. And last but not the least, we should know how to read the X-ray. Then only we'll be able to make the proper diagnosis for hand injuries. So how many views? Most of the times, because of budget constraints in peripheral centers, people do get away with only one view. And what you see here, the lioness is carrying the cub here, and it looks like it is eating away the cub. But it is not the case. The lioness is actually gently holding the cub. So this is the importance of two views, because perspective can change with two views. This is what we saw in that previous perilunate dislocation which I have seen. So minimum two views, and most of the time multiple views are better to get a proper diagnosis. So importance of multiple views in the OPD, when we are diagnosing certain things, when the patient comes to us in the OPD, we have seen this. Never send off with one view because you will miss an important diagnosis that the lunate is dislocated. And you can clearly see that the lunate is triangular in shape. It should not be triangular in shape. Yesterday we had Anil Bhatt's class where he has clearly told us that the lunate should be trapezoidal in shape in the PA view. And here also the lunate is completely out. So that is the reason we have to take multiple views in the OPD. Similarly, importance of multiple views in the OT. Sometimes we get very much satisfied with our fixation technique, and we think that it is good. But what happens later when we see in the OT is that the reduction is not adequate. So that is the reason we have to take multiple things even in the OT. So what views are needed for what fractures? So for finger fracture, true AP and lateral is needed. Do not take a hand AP and oblique for finger fractures. For hand, you can take AP and oblique. Wrist, always it is PA, never AP. And scaphoid, take PA in ulnar deviation, lateral, and 45-degree pronation oblique. These four are the standard views for scaphoid. So again, we have seen this injury first. For finger, never take AP and oblique. Always a lateral thing will give you a clear-cut image of the PIP fracture dislocation here. So in AP, it may look like it is normal, but when you take lateral only, you can understand. Similarly, coming to wrist injuries, always confusion arises whether to take AP view or a PA view. So never take an AP view because clear-cut diagnosis cannot be established with the AP view wrist injury, always a PA injury. But how do you know, some patient has come to us with AP view and two X-rays like this, how do you clearly make out whether it is which one is AP and which one is PA? Anybody from the PGs can answer which one is AP and which one is PA? Yesterday we had a very good class. Anyone? Yes. So you based it based on the ulnar styloid. When the ulnar styloid is outside, that means on the most ulnar aspect, that is the PA view. And also the girdle arcs are concentric. The lunate is trapezoidal in shape. Here the scaphoid is flexed and the ulnar styloid has gone too much radially. So that is the way which we can directly say, as soon as we see a X-ray, we can make out whether it is AP view or a PA view. And also in a PA view, you can clearly see that the radius, capitate and the metacarpal all are collinear or parallel, but that does not happen in a AP view. And again, the ECU groove is clearly seen here on the ulnar aspect, whereas it is more medial in a AP view. And also scaphoid is in a good profile in a PA view, whereas scaphoid is flexed and it is the good profile of scaphoid is not seen in a AP view. So sometimes patient comes to us with a scaphoid scuff marks, pain, and then you get a AP view. The scaphoid is flexed and you may tend to miss a lot of fractures in the scaphoid too. So always a PA view is essential. So again, coming to scaphoid, many views have been described in the literature, include such a huge list and so many other things also. Why do you need so many views for scaphoid? Scaphoid, by name, it is called navicular bone. You may be thinking that it is as simple as this, but it is not as simple as this. Scaphoid is a very crooked bone. It is in a torsion, three-dimensional torsion. It is very obliquely placed. So whenever you are getting an X-ray also, the fracture site which usually happens in a transverse plane of the scaphoid, when you are placing normally the hand in PA view also, this fracture can be missed. So that is the reason we have to do some maneuvers and positioning so that the fracture site comes into place and then we get a good view of the fracture. So four standard views are for scaphoid: PA in ulnar deviation, lateral and 45 degree. These give the maximum three-dimensional information about scaphoid fracture. This is the PA view, hand facing down with ulnar deviation. The whole scaphoid profile comes into picture, and the lateral view, regular one, and semi-pronated oblique. These are the views which are very much important. And next, how to position the hand. So getting a proper view is important when taking an X-ray. You have to be always in touch with the radiologist to get this done. And Usually our radiologist takes the X-ray in this position. Even if we write a peer view, they do X-ray in this position. This is not a correct position. This is always a wrong position. Do not take peer views in this position. Always the shoulder should be abducted, elbow flexed to 90 degrees, and then PA and lateral have to be taken, because that is the position which avoids rotation in the forearm, and then only we'll get a proper PA view and a lateral view of the wrist joint. So next is, after you do all these things, you should be able to read the X-ray properly. Then only you will be getting a diagnosis properly. So knowledge of the radiological anatomy is very much important. And as the saying goes, the eye does not see what the mind does not know. So if you don't know what is there in the radiology, you definitely will miss the diagnosis. So that is the most important thing. So reading a wrist X-ray is like decoding a Da Vinci code. It is very difficult. You cannot make what is happening in this picture. So until you clearly see that there's a woman here, there's a bull here, with there's a horse there. So many things. So many things are there even in a wrist X-ray. So first is the Gilula's arc. These are three concentric lines parallel to each other, which are drawn parallelly, and when there is a lunate dislocation, these lines are broken, and again scapholunate dislocation, when these lines are broken. In detail about that. So always examination is necessary before doing any X-rays. So pertain your X-rays only to the necessary part, and know the part where you want to get shot the X-ray. If it is a wrist X-ray, do not order an entire forearm and a wrist X-ray, because the radiological angle also will be different. Proper view and knowledge on radiological anatomy aids in the diagnosis. Thank you.
For your presentation. Now I invite Dr. Anil Bachar to come onto the desk and present a topic on distal radius fracture and how to fix different patterns of distal radius fracture.
Good morning, everyone. When we see the patients with distal radius fractures, the basic investigation all of us do is X-rays. And the next question for both the patient and us is whether it's operative or non-operative kind of management. And most importantly, we need to understand our reduction and our treatment depends on the stability of the fracture itself. So this is the basic list of what is stable fracture here. If it is more than 50% combination, it's an unstable fracture. If the angulation is more than 20 degrees, especially dorsally, and if there is a shortening of more than a centimeter, or the fracture pattern especially is this ulnar pattern kind of fracture with a shear, or it's badly displaced, more than 100% displacement, there could be an ulnar styloid fracture with the base especially and displaced, and severe osteoporosis. So all these patients, when we do reduce and try to hold them, they might not stay there. That is the message of this slide, that these are inherently very unstable fractures. And if they are unstable, and it's not wise to hold on with unstable methods, especially KYs or a cast, and if the patient is not able to afford or refuses, please document that and counsel the patient for complications. So this is the basic teaching we all do. And then the reduction depends on where the fracture is. So you have a classification, so many classifications. As a surgeon, you will have to kind of combine these in your mind of where these, which is it a column? Which column is it? Is it a fragment? Which part of the fragment is it? Right? Or is it involving, the mechanism where we know different types of mechanism? Or it's involving the good old fitments where there is DRUJ also. This is the only classification actually talks about DRUJ. And I still find fitments is a very good classification in that sense, right? So you have different types based, this is especially based on the Fernandez classification. You have the bending type, the shear type, and all these avulsion types, comminuted types, complex types, all these. So your reduction techniques also depends on these types. So sometimes there could be, yesterday I showed this, especially a carpal instability with the scapholunate kind of reductions. So Another important thing is your reduction again or your final treatment is based on also looking at the CT itself, especially in intra-articular fractures. As I said yesterday, please reduce the fracture always and then take a CT scan which will give you more information where the fragments are. So a lot of times we see that X-ray and CT are done together. So do a basic close reduction as much as possible the patient allows and then do a CT scan which gives you a better indication of how your reduction techniques should be there, right? And if you decide on a non-operative management, believe me, non-operative management is more difficult than operative management. So if you do that, make sure you follow these patients, especially the first 3 weeks, every week. And at any point of time, there is a displacement or a collapse, talk to the patient and see whether you want to convert it to an operative management or the patient is ready for some amount of complications. So that is the first 3 weeks follow-up. And if there is some amount of reduction holding on and it's acceptable to the patient and you, then you go on with the continue the same method. I think yesterday we were traveling and we saw that one of these patients actually with this cast here and we were feeling bad for the patient. So always make sure those casts are in a proper position and that they don't cause complications. 6 weeks, this is the same patient, 6 weeks follow-up, reasonably healed well and patient is doing fine. Right. So if the operative intervention is required, implant is chosen based on the type of fracture. And we always blame the implants, but it's our choice, right? So what we choose as a surgeon is what the implant does. So it's very important that your reduction and your implant matches. If you talk about K-wires, definitely one of the most versatile implant and one of the most useful implant we have. But again, wrongly used a lot of times or injudiciously used. Comminuted fractures, DRUJ injuries, and also ulnar-sided fractures might not be really useful. Classically used for bending fractures like this, especially your good old Coley's or Smith's fractures, right? So various techniques are described. The basic thing is that K-wire should always cross proximal to the fracture site, not at the fracture site or not distally there, definitely proximal to the fracture site. And you should check both in the lateral view where they're crossing. That's very important for you to get a good reduction. So small tips there for a good cross K-wire reduction. If at all you have to open or you do a Kapanji kind of a technique, you can use these kind of basic techniques where you can use an osteotome to elevate the fragment to get your volar tilt or even your radial height or length. That's very crucial for us to get back the mechanics. So rarely done, but this can be, whenever we do an open reduction, this could be useful, but otherwise you can use a Kapanji technique and use the K-wire itself as a joystick. Fixators, we should know when to use them, right? Excessive distraction like this definitely is a recipe for stiffness and CRPS. So you look at how almost twice the amount of radiocarpal space, that is your guideline. So you have a normal radiocarpal space about 2 millimeters and twice that. If you are distracting too much to just get the reduction, it's definitely not worth it. Okay, and one of the things you can do is in your, when you start the case, you can just do a traction view and see where these fragments are falling. And if they are not reducing, see the amount of traction here, right? It's the midcarpal space is completely opening up. So if you know that this is the amount of distraction required, definitely it's not worth it. So sometimes you can combine your K-wires with your external fixators so that you don't really have to do that amount of distraction. You can pin those small fragments which are not moving separately, use the K-wires as joysticks, fix them, and then you can use your external fixators. You can have best of both. Tips for plate osteosynthesis, general techniques. Again, restoration of volar tilt. You can use your plate for your advantage, right? You can use the plate in this manner, keep it at an angle, how much of volar tilt you want here, and once you press the plate down, you will get back your volar tilt. So take the advantage of the plate itself. Coronal fractures like this, you can have an additional K-wire like this, especially a depressed fracture here at this point, and a split fracture here. Elevate that fragment again with your K-wire, use it as a raft kind of a wire here, hold it, and then you can put your plate at that point. Volar lip or depressed fractures, right? You can use your levers or osteotomes. I've used a punch here actually at this point to go all the way. There's an intrafocal kind of thing. So you have to push those fragments gently up to get the articular surface back, and then you would get the reduction. A lot of times you see this radial displacement. The culprit here is the brachioradialis always. Okay, so can you just click on the video? Elbows. So always go till the radial side and take off those brachioradialis. That is the culprit there. So once you take away the brachioradialis here, it nicely comes back at this point. So we normally don't expose so much here. We always feel scared that we are trying to go very radially, but that is really worth going there. Or you can use a Bristol like this and push this fragment. You should make sure you see this interosseous space, the arch, the Gothic arch concept there. So you should make sure that arch comes back here and this radial translation can be. So one of the most common problem or stiffness reasons is actually this radial translation. This is another case. Basically it is, if you look, this is a major fragment here, a lunate facet fragment. Okay, and that is what it is. If you look at the CT there, you know why this is the problem. So these are very dangerous injuries in the sense that they usually have a late collapse, however nicely you fix, okay? And you need to use a lot of techniques here. The lunate fossa itself, so you need to go directly there at this point, engage the fragment, push that fragment up, elevate the fragment here. You use your levers to elevate the entire depressed articular surface. Use a raft like this at this point, okay? And then you can use any of these techniques, cross K-wire there. With the plate, you can keep the wires if you want, but if you feel the plate is holding on nicely, you can take off the wires later. Okay? So that additional screw is also very useful a lot of times. I think yeah. So if you want, you can put an extra screw there at this point. After that, you can fix your plate onto that. So no need to hesitate on that. You can put a headless screw or even a cortical screw there. So that extra screw there will hold on to this. Have at least 2 screws from your plate towards this lunate facet fragment. Very, very important there. Okay. Sometimes you have a dedicated plate here at this point. A video, please. Okay. So that is the lunate facet fragment. And there are plates designed for this. These are the hook plates. These tines of the hook plates just go subchondral at this point. Okay. And you can place that separately at this. Right, and that's the fixation. These are very bad rim fractures. It's almost like a burst fractures, very, very distal. And you do have, so you need to see where these fragments are. These are free floating fragments here at this point. And you need to have very flexible approach here. You have these rim plates here which go all the way, they cross the watershed line here. They are low profile at this point. These screws actually go proximally, not distally towards the joint. So very important kind of a design, and you can hold them on like this. This is 2 years follow-up here, and a lot of times only thing is you don't really get this volatile with these rim fractures, very distal fractures at this point. Can I have 5 more minutes, sir? These basic methods, especially in distal radius, elderly patients, they work really good even now. So make sure that these are taught, and I urge the teachers here also to teach these. And we should not be, stopping all these things. So the beds, the correct way, the extent of it, how they have to hold the limb, post reduction, post plaster, how they have to maintain the plaster. I think all these has to be still. We need to go back to those days and make sure that our juniors, our younger generation learns all these techniques. Especially, I see here the plaster is completely almost towards the MCP joint, right? It should never cross the proximal crease. Make sure the MCPs are free always. The thumb is always out, abducted like this, so that the patient keeps moving this. Instructions of moving the elbow, shoulder. A lot of times we do get this typical shoulder hand syndromes, stiff shoulders, stiff elbows, where the plaster is put for 6 weeks. So these are things I think we need to make sure, especially the thumb. The thumb moves at the CMC joint, so that clearing has to be there. A lot of times the plaster is still here, almost here, and severe pain and stiffness. And nowadays with the new Apsocast and Articast, the fiberglass casts, it might be cutting through the skin. So we need to be very careful with these things. As I said, fold all the way till here, and make sure the palmar crease is completely free so that the MCP joints are completely free. So these are all small steps, but very, very important steps for us to learn and to keep teaching our juniors and the younger generation. And always clean up the entire area. I always insist on my postgraduates to make sure that all the nails are free of plasters so that you look for circulation. Patient is able to do this very nicely. Okay. And if you want, you can reinforce with any of these fiber casts at the end. Right? No sharp ends there. If there are sharp ends, make sure it's nicely, padded with the elastoplast, any of these things. Thank you so much.
Now I invite Dr. Abhijit sir to come onto the dais and give the presentation on perirunate fractures.
Pune, and at the morning everyone, and at the outset I would like to thank the organizing committee and especially Dr. Gopinath Bhandari for the invitation to this August meeting. And my task today is to talk a little bit about perirunate injuries and especially try and focus on how not to miss the injury. And these are injuries which are extremely common, and this is especially for the postgraduates and the residents, that whenever we are in the emergency room and we see a patient with multiple injuries, we tend to focus on the larger bones or the more obvious, and then the subtle injuries are often missed. So here is a patient who is a 21-year-old trichon-dominant person. He had this injury, it was fixed very well. All the anatomy has been restored, and then he started developing some pain later on, almost a year down the line, when he presented to us with wrist pain. And obviously that begs the question as to what is it that we are missing. And here you can see that his wrist movements have been pretty restricted. And these were the initial x-rays, so we thought we'd go back and visit the initial x-rays as to what was missed. And just like Gopinath had mentioned, it is often inadequate exposures or inadequate films, and trying to visualize everything in one frame, which causes the missed diagnosis. If you look more closely here, again, these are not the proper films that we should be having, but you can see that there is something wrong with the lunate, which was talked about, and then when you get proper x-rays, this is what you see. So this was an injury that could have been diagnosed, could have been treated appropriately, only for want of proper x-rays and focus on the more obvious. This injury was missed, and an otherwise good outcome was not possible. These are again MRIs of the same patient, and you can see different patterns. So what are perirunate injuries? These are high velocity or high energy injuries resulting from a fall on an outstretched arm. There are usually multiple injuries, and what's interesting is that about 25% of these injuries will be missed, even by experienced and senior orthopods. So they are often missed, and immediate presentation is more often the norm. And like I just mentioned, these are injuries that are the result of a fall in an outstretched hand, that is a torque element that is added to the actual compression. And these are devastating injuries because they cause a severe disruption of the carpal anatomy. They are uncommon and they are challenging injuries, and they account for about 7% of all carpal injuries. The patients present with a swollen wrist that is painful, the movements are restricted, and on palpation you'll often find a dorsal prominence somewhere around the middle of the wrist. So whenever you see a patient with a swollen wrist, a history of fall, and you find these findings on your clinical examination, start thinking of a possible wrist injury in terms of a perirunate injury. The wrist and the digit movement is often restricted, and that is usually because of pain, and the fingers will assume a semi-flexed position. So all of these pointers are towards diagnosing a perirunate injury. You need to examine the patient for median nerve compression neuropathy because the lunate might be displaced polarwards, causing median nerve compression. And this is the cornerstone of diagnosis. This is what we will focus on. So the highlight of this entire, or the crux of this talk, is to understand how not to miss these injuries. And again, at the cost of repetition from the first talk until now. It is always inadequate exposures and inadequate radiographs that lead to missing the diagnosis. And 20% again are misinterpreted on initial radiographs. So all these points have been discussed earlier on. So I don't have to belabor too much on this, but the repetition is only to help you understand the importance of taking proper X-rays, knowing what is normal, and then going from there to what is abnormal. What are the views that we need? We need a good posture-oriented view, a lateral view, you need two oblique views, and then whenever possible, a traction view to delineate the fracture that may be associated with these injuries. The posture-oriented view is where you look for the carpal relationships, especially you look for the much talked about guidula arcs. I'm sure you've been hearing about this for the last 2 days. And then also look for any changes in the carpal height. Look for the scaphoid, and the lunate is actually your key kind of a lead to diagnosing the perineal injuries. Again, this has been talked about. The lunate should appear trapezoidal, but if it appears triangular, it means that there is something happening with the injury. Here is a traction view where you can see that there is a fracture of the radius styloid, there is a fracture of the scaphoid. There's something happening here. Obviously, this doesn't look good. This doesn't look normal. So there is something that is happening. Again, the lateral views have been talked about. You look for any dorsal displacement of the carpus, the so-called spilled teacup sign of the lunate, and all of these put together, along with the clinical examination and the history, it's very unlikely that you'll miss a diagnosis now that you know what to look for. So I won't belabor too much on this because this is beyond the scope of this talk. I'll very quickly skip to the volar aspect, where the weak area, which is the space of Poirier, this is where the lunate will escape from, that's a trap door through which the lunate will come on the volar side. Just a very quick overview of the classification. This is a Mayo classification wherein there are certain acronyms that are used to define these injury patterns. Again, I don't want to add too much to the confusion, but just a brief overview so that you know the instability patterns. And then the carpal instability, or the transscaphoid perilunate instability, is a component of something called as the carpal instability complex. Again, I won't belabor too much on this. Suffice it to say that there are two patterns that you should know of: lesser arc injuries and greater arc injuries. Very simplistically put, greater arc injuries are where there are fractures associated with the dislocation. Lesser arc injuries are where there are only ligament injuries, and this is the key differentiating factor between greater and lesser arc injuries. So perineal injuries is basically a continuum, pretty much like the Logge-Hansen classification for your ankle injuries. We have something called as the circle of Mayfield that pertains to the wrist, just like what you have for the elbow, the circle of Hori. So this is how these injury patterns will occur, going through the bones, going through the ligaments, and there may be permutations and combinations of different fractures and different ligament injuries that you will see. The treatment usually is surgical, but this is just to kind of complete the flavor of the spectrum of treatment options. You may also at times in very immediately presenting injuries attempt a close reduction, and if not successful, take the patient back to the OR. The treatment will depend upon what injuries are present. You would often require open access to these injuries. The most preferred access is the dorsal approach, but you may have to use a combined dorsal and a volar approach. There is also some interest in arthroscopic reductions. Here is a classical example wherein you can see that the screw has been used to fix the scaphoid. There is a suture anchor here, and then you stabilize the carpus using K-wires. There is something called the scapocapitate syndrome
for your presentation. Now I invite Dr. Sunil R. Sir to come onto the dais and present the topic on preferred fractures, do's and don'ts.
organizing committee for giving me the opportunity, and thank you, Chairperson. So I'll be giving a brief speak about the do's and don'ts about scaphoid fractures. Usual to see scaphoid fractures, it constitutes about 60 to 70% of the carpal fractures. So interesting fact about scaphoid is anatomically about 80% of the scaphoid is covered by cartilage. So there is a very less space for it to receive blood supply. And it is got a twisted architecture. So knowing exactly where we are exactly on the C-arm angle is also very difficult. And biomechanically, it forms a link between the proximal and distal row. And there is a huge amount of stress on this scaphoid. And there is always a tendency of the scaphoid to flex. Biologically, there is retrograde blood flow to the scaphoid from distal to proximal that has an implication because the increase in avian scaphoid fractures. So complications are seen because either of these 5 factors, either missing the initial fracture, lack of immobilization of the undisplaced fracture, or trying to immobilize an unstable fracture, improper surgical technique, or the wrong surgical option. So I'll just, all these are to prevent the non-union, which is about 4 to 50%. And there is a high incidence of snap collapse if non-union is left unbreakable. So when to suspect this scaphoid fracture? History of fall with tenderness in the anatomical snuff box is highly sensitive. Next best is tenderness of the scaphoid tuberosity. Sometimes an axial compression along the thumb can detect it, and the initial hematoma can cause swelling at that moment. What is the appropriate imaging? As we have seen earlier, the 4 standard images for any suspicious scaphoid fracture are the PA with ulnar deviation, lateral and semicone. These 4 series of X-rays is a must when you suspect it. And whenever in doubt, for occult fractures, CT is required to rule out other injuries like peroneal injuries if may be needed. For combination displacement, and even if after 2 weeks you still suspect a fracture, you can go for a CT to reassess it and to assess the union after fixation of 3 months. So that's the role of CT in scaphoid fractures. So a subtle looking injury can look very bad on a CT. So that's how the CT can actually give you the exact picture of the scaphoid fracture. And MRI has a role. When you have a suspicion very early within 24 hours, you can find a T2 hyperintense line at the fracture site, and it's also useful to assess the AVM. So how do you go ahead with your plan for treatment? Whenever you suspect a scaphoid fracture, the patient goes into a cast for 2 weeks. And again, these 4 reviews are taken out of the cast at 10 to 14 days. And after 2 weeks, if the patient is symptom-free, you can just leave it. And if after 2 weeks, there is local tenderness, probably you can continue the cast, or you can get a CT to confirm the presence or absence of a scaphoid fracture. And coming to the undisplaced or minimally displaced fracture, which is a common out of all of these, there is always a debate between immobilization and internal fixation. It's always an informed choice between you and the patient. The benefits of surgery in such undisplaced or minimally are short-lived. So there are numerous studies which actually have been brought into this calculation. So for percutaneous fixation minimally displaced, the benefit is time to return to work is early, time to union is early, complication rate is slightly higher. There is a short-term benefit of range of motion and grip strength improvement. But the patient satisfaction at the end of probably 6 months, it doesn't matter. So the primary benefit is short immobilization and early return to work. And you also have to consider patient's perspective, right, cost and his apprehension for surgery. So it's always an informed decision between you and the patient that has to go into this decision. And if you're going for non-operative treatment, how to get it right? So immobilization is with a cast. Whether to include the thumb or not is again controversial. If the patient is non-compliant, it's always better to include a thumb, but allow the IP joint to the thumb to free. In spite of casting, there is a 10% of chance of non-union with the minimally displaced fracture that has to be explained. And if at the end of 6 weeks of cast, there is no pain, no snuff box tenderness, and the fracture cannot be seen on radiograph, you can remove the cast and just follow it at regular intervals. But if at the end of 6 weeks of cast, if there is still no evidence of union and gap is seen, then you have to take a call, proceed with or without a CT scan and advise the patient for a fixation. What are the indications for stable? Any humpback, deformity or collapse of the scaphoid is unstable. Any combination is unstable. PLFT is unstable obviously, and if there is zonate amalaran it is unstable, and proximal pole fractures are always unstable. So these 6 they have to go for, or rather you shouldn't be putting in them in a cast.
Coming to displaced scaphoid fracture, what exactly is displaced? Even a 1 mm of displacement is supposed to be considered displaced. So there is a high chance of 55% of non-union even which is minimally displacement. So anything more than a crack, any translation, gapping or angulation, you have to go ahead with your internal fixation. An undisplaced proximal pole fracture, approximately 20% of the scaphoid is considered to be the proximal pole. Whether displaced or undisplaced, the proximal pole has to be operated because of these factors. Because of the high rate of non-union, there is chance of avian, there is biomechanical disadvantage because of the large lever arm stress, and it's purely synovial fluid past this fracture site, and there is less chance of dealing with this proximal pole fractures. Because of and the distal pole is a very stable configuration. Usually, for any tuberosity or distal pole fracture, the patient needs to go into a cast for 6 to 8 weeks. And coming to the implant, what's the choice of implant for your fixation? For a scaphoid fixation, there are 5 factors which determine the outcome. But out of these, only 3 are under your control. This is a fracture reduction, choosing the implant, and implant placement. So there are very many kind of implants. KYs still used. The original Herbert screw was a non-cannulated one. Then came the Herbert Whipple, which was a cannulated version. And what we use now is second generation headless screws. So you need to know what screw you are using. If you see the Herbert screw, which is a local made Indian screw, what we see, it has got a differential pitch. The leading pitch is larger than the lagging pitch. So you get compression by countersinking the screw. If you see the HCS from the sink piece, there is no pitch difference, and compression is by the sleeve actually here. You can see that sleeve which is being used, and once the sleeve is loaded onto the screw, it becomes a lag screw, and you just have to bury the screw. So the countersinking doesn't give any compression for this HCS screw. If you see the HBS screw, this has got a differential pitch as well as a compression sleeve. It has got a dual benefit, and if you see the RCH FT compression screw, it's a fully threaded conical screw. So knowing what is the screw, how you get the compression, what's the instrumentation of that screw is very important when you're dealing with these fractures. And choosing the correct approach. For a percutaneous volar, if you don't, most commonly used is a percutaneous volar approach. Access is gained by ulnar deviation and extension of the wrist. But it's easy to do, but it's exactly not that easy to get into the central axis of the scaphoid. The technique is that the guide bar is entered from the radial part of the scaphoid. You go for the 4 views again on the C-arm. Length of the guide bar is measured to deduct 4 mm from the length. Ream it, insert the screw with compression under fluoroscopic control. So that's how the guide bar goes from the radial half of the distal pole. And all the views on fluoroscopy have to be confirmed before going with the drill bit. And that's the final position of the screw. Looks satisfactory. The other approach is the dorsal percutaneous approach. Here there is difficulty in imaging. There is chance of displacement, but the screw position is very close to central axis. Here the wrist is flexed and pronated, and what you try to see here is the flexion of the scaphoid, and you have to aim the guide bar towards the ring of the center of that ring. And again the screw measurement and everything is the same like in the volar percutaneous approach. If there is significant displacement, you can use percutaneous techniques or arthroscopic assisted techniques. And if you are not still able to do it, there should be no hesitation to open the fracture. Commonest is the volar open if it's a waist fracture, and if it's a proximal pole, you go for a dorsal. So if you compare volar to dorsal, dorsal is mainly for proximal pole, and for waist, if you are quite used to it, volar is predominantly for waist fractures. And regarding the screw, more parallel to long axis, more perpendicular to fracture line is the dorsal. The complications are different. With dorsal, you find extensor tendon because that's where you enter. With volar, you find a proximal screw penetration, which is usually undetected on the C-arm images. Coming to proper technique and sequence of fixation. Implant placement, whatever way, it has to be central and long enough. These two are the most important biomechanical parameters which are supposed to be stable. And you have to visualize under fluoroscope. And always move the wrist after finishing your procedure to look for crepitus and proximal screw migration. So this is one such X-ray where the screw looks to be alright, but there is patient came with dorsal pain, and if you see the tip is actually pointing out from the proximal end. And that's the fluoro imaging showing it has actually penetrated, and that's the screw which is seen from the proximal pole. So this can be avoided by continuous fluoro imaging on table. This is another screw insertion gone horribly wrong. Here the problem was lack of orientation. The screw was tried to put from the proximal pole, but the entry was volar, which is almost impossible. So you have to know that you have to enter from the dorsal side from the proximal entry. And this is a wrong implant size, a large screw. Thank you very much.
Thank you, sir, for your valuable information. Now we request Dr. Neeraj sir to come on the desk for an interesting short case discussion.
Good morning, everybody. I'm Dr. Neeraj. I work as hand and wrist and reconstructive microsurgeon in Akash Hospital in Delhi. So I'll be presenting a case. This 19-year-old girl, she presented to us after the injury. So she sustained injury on her right hand, which was a dominant hand, and she sustained a trapezium fracture. So, but now she has presented to us with complaint over the pain over the MCP joint. So these were her initial X-ray. This was the initial X-ray. If we can see here that the trapezium is fractured. Okay, thank you. So considering this X-ray, there are multiple options that are available. We can do a K-wire fixation percutaneous, or we can put a headless screw. So the operating surgeon who was operating on her put these screws. So and after 1.5 years, they removed the screws, and after that the patient came to us. So when she came to us, this was her clinical photo. Can we play the video, please? Video. Yeah, so her main problem was not at the CMC joint, her main problem was at the MCP joint. So there was a subluxation, or we can say instability of the MCP joint of the thumb. And it was a dominant hand, so she was not able to do almost all the activities. So considering this, so these were her X-ray at that time. So we can see there is a Z deformity of the thumb, and there is some arthritis of the CMC joint, but there was no complaint of any pain or any restricted movement at CMC joint level. Once even during the examination, when the MCP joint was stabilized, she was able to extend the thumb nicely and abduct the thumb nicely. So considering this, we did an MRI. So on MRI, we found that there was no, you can see here, so there was no capsule on the volar side. So there was absolutely no capsule on the volar side, and the ligaments, the collaterals, were also very thinned out. They were completely flayed. So we planned to took her to theatre. So the main force which was causing all this was the EPB. So in theatre, this is the EPL and this is the EPB. So what we did in this case, can you please play the video? So we have cut the EPB from the proximal part, and we have sutured it over the EPL, and we have centralized the EPL so that there is good extension of the thumb. And here the EPB has to brought out on the volar side below the FPL, and it should be like that there should be no restriction of the FPL movement. And then you need to put you need to drill a hole at the level of the neck to bring the EPB back on the dorsal side to stabilize the MCP joint. So it will act as a volar capsule as well as a extensor stabilizer. So can you play this video also? Thank you. So we have taken it out on the dorsal side, and after this the MCP joint was completely stable. All the movements were completely good, and we have sutured it back over the dorsal aspect of the MCP joint, and the centralization of EPL even gave a good result in the EPL extension, and so this was something different that is written in even in our books. It has only half of page. It is known as the Vessel's procedure, which is specifically for chronic MCP stabilization, and it is one of the very rare thing that usually happens and very rare performed procedure. Thank you. I don't have the follow-up photo, but the child is doing completely great, and she has almost normal movements. Thank you.
Good morning, everyone. Thanks for the TOSACON and organizing committee for giving me this opportunity. I am Dr. Ashish, working as a consultant hand surgeon in the Department of Orthopedics in MRI Medical College. So I am just presenting the interesting cases. So this is a 19-year-old male who has presented with a runover injury for the dominant hand. With the dominant hand, and this is the presenting clinical image and presenting X-ray. So there is a distally avulsed all long flexors and soft tissue and the distal deglobing. Next, so this is the presenting X-ray which is showing the both bones forearm fracture. So the various options, first we need to assess them clinically. Okay. We need to assess them clinically. So what are the clinical findings? So we need to see whether the sensations are intact, the distal vascularity is good, neurological is good, and what are the available flexors. So in these crush injuries, we cannot determine what flexors are working initially. So we can see intraoperatively after the debridement. So we plan it, how to debride it, and what is the mode of stabilization, and when we need to cover the flap cover. So among all, the debridement is the key for getting a good result, and the skeletal stabilization, we need to do a proper skeletal stabilization and wound cover. So this is the triangular concept which should be followed in all crush injuries. So how do we debride? We do a layer debridement, or we remove the distally avulsed muscle which are avascular, distally avulsed skin which is avascular we need to remove, and all longitudinal structures should be preserved which are intact. So this is the wound, all the distally avulsed we need to remove it off, and after the debridement the wound should look very clean, and the longitudinal structure should be preserved. So skeletal stabilization. Unlike in lower limb, the external fixator and rationaling concept should not be done in the upper limbs, because we need to have a very good stabilization, anatomical and stable fixation. That will help in it reduces the infection, reduces the deep space, and early rehabilitation can be initiated. And the effective length of the long flexors and extensors will be maintained with the stable fixation. So we do a both bones forearm fixation for this. And timing of the wound cover, this is what is to obtain a primary intention without with a minimal tissue reaction. This is the concept given by Buckhalter, and the excellent results will get with the primary care. That is the initial cover of the wound immediately. But disaster happens in the judgment phase. That is, we should do a proper debridement. Okay. So after the immediate paraumbilical flap was covered, to cover the entire defect, 3 to 4 weeks is the time period to delay and divide it. And this is the result we get after the 1 year follow-up with the completely united both bones and very good functional outcome. Even the pronation, supination, everything is maintained in this hand. So the key is debride it properly, do a good stable fixation, and early mobilization is the important thing, and early immediate flap cover to cover the defect. So this is the final result, and this is the donor side wound. So next case is as Bandari sir has already told, how we will miss a injury. So this is a patient presented within 2 days. Lateral view we take, there is a volar lip fracture with a subluxation of the PAP joint. So what are the options available? So in this case we need only the axial traction that can be given by a Zimmer splint. Even we can go to extension block pinning, or we can do a switch key frame. So the advantage of switch key frame is it can be done in local in the ring block, and we can immediately start mobilization for the patient. So this is the way to put one parallel wire to the joint in the PPX head and one in the MPX head parallel to the joint, and this is the extension blocking wire. So usually with extension, the joint will subluxate. So this should be more volar such that whenever we flex, this will push the middle cable to the volar side. So this, once we apply the traction, this is like aeroplane takeoff sign we need to see. The finger flex, the splint should be in the takeoff position. So we need to immediately start encouraging the passive and flexion and active flexion from day 2. Frame removal will be done after 2 weeks. That is, once the fracture site tenderness disappear, by clinically we can remove the frame.
Now we request Dr. Santosh sir to come on to the desk for short quiz discussion.